Well, greetings, everybody who's rolling in right at 11 o'clock. My name is Barbara Pelletreau, and I'm your host for today's meeting. We'll get started in just a couple of minutes. I want to allow those 1 or 2 extra minutes to transition from one Zoom call or one WebEx to the next, and then we'll get started. We have a great program lined up for you and fabulous speakers and experts. Well, knowing that we have a really full program and knowing that it's 11:02, we're going to go ahead and get started. So our program today is how to transition a CRP case to claims. And I think you're in for a real treat today to be able to hear from 3 distinguished panelists that have a different, not different, but very complementary and unique perspectives on how to make this a smooth transition and certainly meet the needs of our patients and our families. So with that, I'm going to go ahead and go through a couple slides and kind of set the stage and introduce our speakers. So with that, just a moment, here we go. So first of all, my name is Barbara Pelletreau. I'm Senior Vice President of Patient Safety for CommonSpirit Health, and I'll be your host today. And I want to set up the objectives, put a little bit of background out for today's topic and foundation. And then if the world is perfect, we'll get through 3 claims case studies today. And if we have rich content, discussion, questions, we get through 2, we're going to consider that a success as well. So first of all, our learning objectives today. Want to learn the practical advice from claims professionals on how to transition a CRP case to claims. And we'll talk a little bit about terminology in just a moment. Our second one is we want to describe several of the key components for an ideal partnership and transition to partnering with our claims for insurers, patients, families, and certainly other key clinical leaders that are involved in the process. And the third, we want to understand the needs of the patients and families and how and when to appropriately engage with them and through this process. So certainly we have 3 distinguished panelists that are going to be commenting on each of the case studies. And prior to that, they'll be giving their a few of their high-level thoughts on this process. So we have Claire Hagan, and she's Director of Risk Management for Providence St. Joe's. Glad to have you, Claire. We have Brittnie, she's Claims Manager with COPIC, works with the Army insurance side with physicians. And then we have Linda Ubaldi, who's been doing extensive candor training across CommonSpirit Health and is also former quality risk and patient safety officer for a division. I'm sorry to say that Jack and Teresa Gentry were not able to join us today, but I do have some comments from them. They had an unexpected family need that came up, but certainly those of you that know Jack and Teresa Gentry will know that they have a great story and they're willing to share it and be part of our journey as we improve our CRP and Candor processes. So with that, I first want to say there's no conflicts of interest today from any of the speakers. So a few slides just for those of you that may not be familiar with the CRP Candor process. First and foremost, thanks for joining us today and learning more about this. There are 5 parts to the Candor process, and certainly trying to put this in pictorial. This is probably one of the best that I have seen. Identification of a Candor event and immediate identification of an event, an unexpected event that occurred. And it may mean that, I use the word unexpected, saying that it might be something that shouldn't have been done or should have been done, or it may have just been unexpected. But certainly the key here is it's unexpected, and we want to connect with the investigation and activation of others that need to be involved with Candor in the investigation. You can see in step number 4, the investigation, the analysis, and then certainly number 3, the response, the communication, not just with the clinical team, but also with the family and patient. And then the final part is resolution, and what does that mean? And so we're going to focus today on the resolution piece of this process. The next part is I added in this slide so that you can have a little more definition of each of these components. And certainly, although they're linear here, they're very interactive and vibrant in how they actually occur when an event, a Candor or CRP event occurs. A couple things that came up in preparation for this is the terminology. So some of the more traditional terminology you would hear would be, we're going to work with the claims manager, the claims professional, on the 5th part of the Candor process, or we may call them a claims manager, or they may be called a claims consultant, or there's some organizations, as Brittney will share with you today, that actually call them a Candor or CRP specialist. And then there's also others that say we have an early resolution team. So in the claims insurance world, they may not be using the claims professional, or they may have been specially trained and they work on the early resolution teams. And then certainly also we often say the word risk manager, and many organizations, as they've broadened to adopt Candor, have realized that that may not be the best terminology for meeting with a patient and family, and have broadened it to a terminology of patient safety officer. So just want to throw that terminology out, not to confuse you all, but I think it's represents, the titles are evolving to capture the essence and the intentions of Candor and CRP events, and so pretty excited about that. The next part is that sometimes when you use terminology, now there are 4 states that have passed legislation that's very specific to CRP and Candor, and I've listed the states here for you. So certainly we may be talking, and when you say something that occurred, those in that state, it has a very specific definition because of legislation. We're not going to get into that today, but I just want to call that out. And we're starting with step 5 today, but I also want you to know that there's many other webinars that talk about other parts of this. So we're not going to cover it all. Certainly, if you want CRP Candor 101, make sure you mark down June 24th for that. But you can see the other list of webinars. And yes, these slides will be shared and pushed out to all that are participating. The last part before I move to our speakers and have them give opening comments is our approach today is certainly to provide an overview and set some foundation. And before we move into the 3 cases, they're each, the speakers are going to have a couple minutes to put out some comments and some perspectives from their expertise. And then we'll move into 3 cases, and we'll move in such a way that will show the case, the story. Then we'll have each panel panelists go through and present a couple minutes on how they would approach this and their thoughts, and then a couple comments on case resolution. And then we'll wrap up with a few slides on the key takeaways. So with that, what must be in place to have a strong, successful partnership with claims, your early resolution team, whatever terminology you'd like to use, but for now we'll use claims early resolution team for the CRP, and I know some use Candor in place of CRP. So there you go on that. First, I would just like to share, if Teresa and Jack were here, what they would share is from their patient, their experiences, what they think is most important for the key components, or what we would call the principles of CRP cases. And certainly communication, being honest, open, consistent, empathetic, well thought out is really important. And that you have an assigned contact person. This is typically your patient safety officer, risk manager in the organization. That the patients and families are listened to and feel that they have been listened to and heard. And then being transparent with the information. And sometimes that's very hard as clinicians, but the expectation is what I call total transparency. And then last but not least, to ensure early and often communication and intervention. And those of you that know Jack and Teresa's story, this was really important to their ultimate outcomes for his healing and where he is today in the organization. And then last but not least, it's about the patient and the family, not about the organization. And I think when we put the people first, the patient and family will be much more successful in the alignment with the organization. So I'm going to take this opportunity to turn it over to first Linda Ubaldi for a couple comments to share her perspectives, and then we'll move to the other two panelists. So Linda.
Great, thanks Barb, and thank you all for joining us today. I'm passionate about candor, and certainly the resolution portion of these harm events is very, very important, not only to the patient and family, but to the organization. Because I think when you have a win-win for patients and families, you have a win for the organization. These bullet points are just basically to ground you in some of the terminology that Barb was talking about, and to understand that not all claims professionals, certainly not all patient safety officers, certainly not all of us that interact with patients are able to effectively communicate empathically. Empathy is a learned art, and there is a science to it, a bit of it. So we recommend that when people are trained and can demonstrate effective empathic communication, that they become part of the core CPR Candor resolution team to manage these interactions. As we said, there really is extensive training that's available, and we encourage that those on the resolution teams are well educated about candor and the approach throughout the entire process, and that those team members work in collaboration with the patient safety officer, risk manager. You know, we have candor teams in each one of our facilities that include senior leadership, and these claims professionals, I think, will align well with those candor teams. The patient safety officer and the claims early resolution team lead should meet prior to meeting with the patient and family to really prepare and practice what is going to be said. We're assuming that the communication to the patient has been consistent, has been transparent, is based on trust. And so when we get into the resolution phase, once again, we need to really identify those questions and concerns that patients and families may have so that we can move the process along. And just so you know, it's generally the patient safety officer or risk manager who has the consistent interaction with families. We consider them the contact person or the liaison, and they typically will remain in that role throughout not only the candor process, but through resolution.
Great. Hey, thank you, Linda.
Mhm.
Great. So we're going to move to Claire for her comments. Claire?
Thanks, Barbara. Good morning, everybody. So, part of my perspective, I handled claims for many years, and now I'm in a different role as the administrator of our early communication and resolution program, and I teach risk management classes. But, when I started out in claims, it was a different setting that you would get the call from the risk manager, and generally we would be the first people to interview the clinicians and the caregivers that are involved. And I think with high reliability, that's kind of shifted in terms of patient safety and risks role. And so in our organization, they are the first ones to do those investigations and those interviews. And the point of laying that foundation is that I think it's really, really important that from a patient safety and risk manager perspective, that you actually get that claims professional on the phone right away, so they feel involved from the very beginning. And it's not this process of you get them the medical records, it could become more administrative. So I think it's really important, and also so that they're in line and in step with the work that's being done internally with patient safety and quality, so that we're getting those records quickly, the x-rays, the pathology, because a lot of times we may not be able to just rely on the internal investigation. Sometimes, certainly there are sentinel events and the liability is very clear cut. In other situations, we may have to get standard of care and causation experts. There may be third-party people involved, so that could be your ED or radiologists who are on contract and not employed providers. And so, it's very complex. And so to get everybody marching along in step, it's really important to engage the claims professional early on. And I think with that phone call where they can get, the real gist of the case, that gestalt that you get, and your concerns that they can keep in mind, I think that's really important. So that story to care, and we all know, the longer you take to speak with somebody, the more you forget. So I think it's really important that that early contact is in place. And then I think the risk manager oftentimes is going to be the one that puts that ED group on notice or that radiology group on notice and make a recommendation that they contact their liability carriers if they have an exposure. And then, taking this further down the line, I know that different organizations handle things differently. And it may be from claim professional to claim professional, but in my experience, often I was in the background constantly with our risk managers in collaboration about how this is going, how the investigation is going, what that patient family meeting is going to look like and feel like. But in many respects, if in the final analysis the care was deemed appropriate, I would not be there in that meeting with the patient and family. I would have helped coach people, been a part of developing talking points with them for the person who's leading that conversation. But I feel that sometimes having a claims person there may send a different message. We always explain that we're happy to work with the patient, or they're entitled to get an attorney, and we'll work with their attorney as well. Next slide, please. So certainly, if there is going to be a meeting with the family because we feel we're responsible, I think it's a good practice to invite the claims person there. That was always my personal preference. I'm not sure that every claim manager feels comfortable in that. We're trying to get to that point, but that's not always the case. Certainly that claims professional needs to have, complete knowledge and insights, and if they're doing a parallel process, they may have gotten independent opinions on causation and standard of care and things and they know the records very well, so they can add some interesting insights into how that communication might go forward too. So I think that it's nice if you are a claims professional. I know that I used to always sit at the far end of the table because at the end, I'm going to be the one that would be introduced as the person that the family or patient would be working with going forward, so that the conversation is really focused on the clinical leader who, and the way I was trained, had those talking points and sort of oversaw that communication and how that was going to go forward. But I think by having a claims professional there, they can sort of be a witness to the interaction with the patient and family and how they felt about their care, and certainly how they feel as a result of that communication that's going forward live. And just again, probably everybody on this call probably realizes you would never discuss settlement at the time of those meetings. That's really down the line, and that's really more, I think, the claim manager's responsibility. But again, that may be different from organization to organization.
Great. Thank you, Claire, for your comments and insights, and certainly your past experience in risk management as well as in claims. So last but never least, I'm going to move to Brittney for her comments. Brittney brings a great perspective in working for COPIC, an insurance company that partners with physicians. So Brittney.
Thanks, Barbara. So just tailing right off of what Claire had to say is when you have your claims professional involved in those meetings, what it gives the patient and family is we hear it from the beginning. And so it's very difficult to not be a part of those discussions and then come in at the end when they want resolution and they don't know what you know, right? But you as a claims professional know about their case, and it can feel like a very cold handoff when you cut off that communication. So moving to when we speak about resolution, a lot of times folks often jump to resolution, meaning a monetary compensation. And obviously we are all aware of numerous cases that resolve in that way. But what we want to make sure everyone is aware is resolution takes many different forms. It's very specific to the occurrence that you're dealing with at that time. And so when you're having those discussions, all of that is to say, what is the best resolution? That's what's going through your mind. What will this family, this patient all need to resolve this case? And it doesn't mean always monetary. So it can mean being heard and seeking understanding, being educated on the care and treatment. It can mean they need an apology. It may mean that they need their needs brought along and yet to be identified. So we're keeping all of those different aspects of resolution in mind as you go through is very important at every stage. It's very important for us as claims professional. We call them candor consultants, working with you through this case, that everyone's keeping that resolution in mind. Your ultimate goal is that resolution is healing for the patient and family, for the providers that involved. That's what your goal of a resolution is how do we get folks to really feel that they can heal from this adverse event. Resolution is successful when it happens on a timeline that is most appropriate for the patient and family. You do not want to rush into these matters if they are not ready. We want to make sure we're keeping in constant communication, but there's a great balance between what that patient or family needs at the time and what the providers need at that time, keeping obviously their current care and treatment at the forefront of the need base, but making sure that resolution can be successful due to the timing is important as well. And as we discussed, it can mean monetary compensation. And in order for us to successfully get to that point, what the predecessors that just spoke before me had said, in keeping everyone that's going to be involved is really going to lead to the best transition into that monetary compensation, if that's where this case is headed.
Great, thanks Brittney and Linda and Claire. So let's move forward with our case studies here. So this first one is process and partnership. And before I give you a minute to read through this on your own, I will say that these cases we've pieced together from different stories that we've had. We've changed some of the facts, etc. And in some, they seem straightforward, and yet they didn't go so well. So I think there's some basic learnings in all of these. And so let's go forward, give you a moment to read through this, and I'll give you 60 seconds and I'll time it, and then we'll go through and ask each of our panelists for their comments. So this one is titled Process and Partnership. All right, so I'm going to change to the next slide here, but don't worry, on the right here has the case study with some of the highlights from it. So we're going to start with asking the panelists what are the issues at play, who should be involved, and how you determine the appropriate resolution, financial, other, what is needed to resolve this for patients and families in this situation. So with that, I will go ahead and ask the panelists to provide their comments.
Well, this is a case that I'm very familiar with, as we've discussed before, this is a case of pretty clear-cut liability. The reason we use this as an example was for the process and partnership piece that Barb alluded to earlier. That really didn't happen in this case. The patient safety officer sort of had a relationship with the patient and her husband, but there really was not any notification to claims and certainly no handoff. You know, and the patient was self-employed, had been there for had been in the hospital in and out of the hospital for several weeks, had not had a paycheck. Obviously, those concerns were foremost on his mind. When the last meeting with the patient safety officer risk manager took place, there really wasn't any plausible reason given why the sponge count was not correct. There was no addressing his needs from a financial perspective, and it was just a poor situation. The patient was given contact information for the claims manager, but that was not initiated, or that connection wasn't made prior to him leaving the hospital. This case actually ended up in litigate. Well, a summons and complaint was filed. There was no litigation because it did get settled, but it took several months for that to happen. And, you know, something that really should have happened far sooner than it did.
Great, thanks, Linda. Brittney, what are your comments after reading this case? What would be your approach and your thoughts to share with the audience?
So I think the first thing that you see when you read through this is communication, right? That word is like the glaring word that you read throughout it is, where's the communication? This is a simple case, right? This isn't complex to understand what went wrong here, or it's not complex in terms of the medicine, right? And so it's should be handled in a very efficient way, and certainly not leading to a summons and complaint being filed. And one of the issues that is at play here is not getting your consultants involved early enough, creating that team of, okay, here's my role. My role is to investigate. So we have the answers of why the miscount occurred, right? Here's my role to make sure that someone's at a point of contact for this patient and making sure they're following up with them and really setting that team out so everyone can be on the same page. And that doesn't happen. And then really the glaring point for me is the cold handoff at the end. So if to the patient, it looks like risk management said, well, I'm done, and claims is introducing them, you know, and they've never heard their name, they've never met them. And so they certainly don't think that this claims representative has any idea what has occurred up to this point. And as we can see in this one, it's because they don't, right? Because they weren't notified early enough. But you need a warm handoff there, and you need to stay involved. And again, until this patient is comfortable with who they're speaking with that claims representative, that risk manager shouldn't sign off on them. They should be jointly together, working together, so they can really make sure that this patient is in good hands throughout the entire process.
Great, thanks, Brittany. And Claire, your thoughts?
Thanks. I think it was pretty well covered. Even though it seems sort of straightforward, you know, a patient may appreciate a personal meeting with the leaders, the nursing leader, or even the surgeon that was involved to show that the hospital takes this seriously, that it, and again, we're at the situation where in some cases, you know, would you have some liability against a surgeon because of this retained sponge? I had a case once where a surgeon left the tail of a sponge out at the end, which was kind of unusual. And, you know, it affected the count that the nurses were taking. At the last minute, he'd pull it out. And so, you know, that was sort of an extreme example. But nevertheless, I think that the point of all this is that we're not only preserving that relationship with the patient, but a lot of times it's their whole family, right? And if we really do it in an outstanding, caring, compassionate way, it will have a major impact not only on that patient, but they're going to tell the story again and again, and maybe even on social media, you know, that we did the right thing, that we were compassionate. And so again, I think in that situation too, the claim professional, it'd be great if they could be at that personal meeting to for that soft handoff and to, you know, that eye contact and that compassion does a lot for people. And they may say, hey, I don't need an attorney, and I feel like I'm being treated fairly and honestly and openly. So I think we can't underestimate these days in particular, the importance of that personal relationship with the patient when it's possible. And even on Zoom, we've been doing that on Zoom too. You can still do it the same way, right?
I would say to that too, Claire, is that it prevents this patient or their family from having to repeat this story so many times, because the more they have to repeat it just to add one more person in, makes them can alienate them in feeling that no one's understanding them, right? So to really say, hey, let's get all the right people in the room so they can tell their side of the story and everyone can feel that, you know, the passion they have behind it all at once, instead of having to recreate that every time for them, I think can go a long way. Because I will say sometimes when by the time it gets to us and they're repeating it, they seriously like, Brittany, I've said this story so many times. I'm hoping I'm not forgetting anything, because you know how you take pieces in and out as you tell the story, because it's so hard to get the whole story in. And I think having all of that at the beginning is helpful for them.
Yeah, I completely agree with that. I think that connection is extremely, extremely important and really needs to flow through the whole process.
Well, great. Thank you, all three of you. Just a couple comments and we'll wrap up and move to the next one. It seems on this one, there wasn't a real clarity in training on CRP Candor, how it works, the importance of investigation. Certainly standardizing how you account for sponges and retained surgical items is lacking at this hospital. And then certainly being all on the same page. I think we underestimate in healthcare how important it is to get on a single Zoom call or in person if you're all at one site, to be able to have a communication on what's the plan, what are the issues, and talk through that. That 1 hour of planning goes quite a long way. So thank you for bringing up those points. In this case, that just quickly, as they brought out the panelists, that the patient safety risk manager should have been and remained in contact with the patient throughout the relationship and throughout the process, and that they should have partnered with the surgeon as well to apologize for the patient. Certainly the patient knows the surgeon has a relationship, and managing and accounting for retained surgical items is a complicated process. Seemingly should be simple, but certainly having someone be able to explain simply what occurred and what's being done is really important. And then certainly making sure the patient didn't receive any bills for their care during the process, and resolution is important as well. So let's move to our second case. You all brought up about communication. This one's about listening to patients. So again, I'll give you a minute to read through the stories, and then we'll turn to our panelists to comment. All right, I am going to bring us all together, and I'll move to our next slide, which again, lovely format, has the basic overview facts on the right-hand side and the same questions. So for this case, I'm going to call upon Claire, and then Linda, and then Brittany. So Claire, do you want to jump in with your thoughts and perspectives on this?
Sure, just to kind of give an overview of the facts too. I think that, you know, in the emergency department, we didn't take into consideration the fact that the patient had this cardiac condition. He had just been on a 10-mile run where the idea of pneumonia came into play was kind of questionable. Certainly, we know that the patient and the family expressed concerns that could it be related to this cardiac condition the patient had had, and it seemed like it was disregarded. The cardiac condition should have probably been a differential diagnosis, right? And then we have a handoff to the hospitalist who did give some consideration to that and fortunately ordered the echo. Unfortunately, the patient decompensated, is transferred to the ICU, deteriorates and is intubated. Again, another handoff to an intensivist who blindly appears to have just reviewed the ED records and the diagnosis of pneumonia, didn't thoroughly review the EMR to see that the echo results were probably available by that point. It's only due to the lack of the patient's improvement that a new intensivist, Ken, another handoff, is on duty, who finds the echo results, confirms that this patient has a severe condition and requires open heart surgery. So unfortunately, it's the patient reaching out to the hospital, complaining about how complaining about how the clinicians didn't listen to the family concerns. And now the patient has PTSD due to being in the ICU and a ventilator. So we would hope that there'd be an in-person meeting with a risk manager or patient safety person to acknowledge that there were multiple system errors, and that we'd like to have the patient and family come in, and we could share with them what we've learned from taking an in-depth look at this care and how we failed the patient and the family. And so in the process of that, obviously the claims person should be notified immediately, as we've already talked about. So they know too that this patient deserves an apology, our sympathy, our compassion. And so again, that the claims person is hand in hand. Probably would want to also get the patient's history and their family's concerns. But I think the important thing is, obviously we let this patient down, we let the family down. It's always an issue of trust when our patients blindly come into our hospitals and think they're going to get good care. And we deserve to acknowledge that we really let folks down. And so with that handoff to the claims professional, obviously in terms of damages, they're going to need to understand this patient's history. Have they had any behavioral health backgrounds? Did they get care as a result of this experience in terms of evaluating the injury? Were they off of work? Did they have extra lost wages because of the delay in care? And certainly this is a case where it appears that compensation is in order in some fact or manner. And as we all know too, that sometimes it's a part of that resolution or reconciliation, as Joe Shapiro points out in the chat, that it may be as important to them that they know that we've improved our processes, that we've learned a lesson, that so whether it's a matter of telling their stories to the staff, other staff members involved, or doing some teaching, but some sort of assurance to them that we took it really seriously, because they're going to live with this the rest of their life, and they hope good comes from the bad.
Great, thank you, Claire. So we'll move to Linda and then Brittany. Linda?
Yeah, I echo everything that Claire said. We know that when patients are harmed by the care that they receive in our facilities, they really want three things. They want open, honest, transparent communication. They want someone to say they're sorry that this happened while they were a patient. I know there's a lot of, angst around that sometimes, that, that's an admission of liability. But I think when it's a really heartfelt, I'm so sorry this happened while you were a patient in our care, it goes a long way with patients and families. And lastly, to Claire's final point, they want to know what you're going to do about this, to prevent this kind of thing from happening, to other patients. In this particular case, they also, I imagine, wanted to know what we were going to do for them in order to get this resolved. But that whole notion of open and honest communication, face-to-face meetings, I think, if we can do it, this has been a ridiculously oddball year, but, even on Zoom, you can see somebody's face and make sure that, we keep that, that connection going as long as we can. So I agree with, everything that has been said so far, and again, I think that apology becomes really important.
So Brittany, what would you do to resolve this case? Brought in as the early resolution team, and the sorries have been said, the facts of how this and what they've done going to do differently is brought up. So what thoughts do you have on resolving this with the family?
So,
financial.
So my hope is that we would have been brought into at this stage, if not earlier, at the very least, to for them to finally get heard, right? Because what you hear here is no one listened to me, no one heard me. We now need to hear that to make sure that they have received that piece. So the claims and folks, and they or your Candor team is going to want to be present for that, so they can really make sure that the first and foremost resolution to this is that this patient and family was heard. And that will be imperative to moving on to the compensation stage of this case. It's difficult for me to take it in 5 bullet points of compensation and where there's so much more to these cases. But I assume that what occurs next is we move to the compensation stage, and you have now built that rapport of hearing exactly, hey, they were not heard, and as a result, there were care concerns in that. So we would, quickly move with the family to get to that stage, because also by the time it gets there, they've been dealing with this for a while, right? Depending on how efficient you were at the beginning. And so now that that you've decided that the compensation stage is going to occur, that part needs to happen for them in a quick transition way, or you're going to rebuild frustration and also rebuild to no one's listening to me again.
Great, thanks, Brittney. So just a little bit on the resolution on this is that communication between the caregivers at a minimal is expectation. Certainly some facts showed that in the electronic health record, it's not always easy to find information. The way it's set up, we don't always have it standardized on where information is housed, and then also expecting clinicians or providers, caregivers to go look for other information. So that whole concept of EHR doesn't always make it easy, but that doesn't matter to a patient and family. It's expectation that we're going to be reading what others and what care has happened and manage the communications between us. That in this case, the patient safety officer and risk manager in partnership with their claims professional, their resolution team agreed that this was not care that they were proud of, and they agreed to provide payment to the patient in this for this and the patient's family and through the process. And I don't know if it's ever really resolved because you just don't forget these things, but in this case, able to move on and reach some type of closure. All right, I'm thinking that we might try for this third case. And so we'll keep our comments incredibly brief. Let me give you a minute to read this story, and then we'll jump right in and call upon our experts for their brief comments. And it will be Linda, Brittney, and Claire for efficiency. How's that? All right, I am going to go ahead and call upon our 3 experts there. I'm going to start with Linda and then Brittney and Claire. If you can keep your comments and please not repeat others, we'll be able to get through this. And then there's a question in the chat box about how do you determine what's fair and reasonable in terms of financial compensation. So let's go ahead and start with Linda.
Okay, great. Thanks, Barb. Again, this case is pretty well known to me, and while it's here in summary, it was really a very protracted investigation to determine that indeed the patient had become disconnected from the ventilator. We had some communication issues and people not really being forthcoming in their assessment of what had happened. To make, whether that makes a difference or not doesn't matter, except that, we notified our claims professional immediately when we heard about this case. Our claims professional sat in on the serial RCAs that we did to determine all the facts. When we had the initial conversation with the family, the claims professional was there with the patient safety officer who had already had an established relationship with the family. It was incredibly efficient the way this happened, and you know, making a medical error like having the ventilator patient become disconnected from the ventilator, you know, is really a difficult message for a patient's family to hear, that but for that, you know, their loved one would still be with us. So it was a very difficult conversation. I think we did an amazing job of staying connected to the patient's family. We encouraged them to get a legal opinion, provided them all the necessary information that they had, and we actually settled this case within about 33 days. So it was really a grand slam as far as it was one of our very first Candor cases, and I think it was amazing, and the partnership between claims and leadership at the hospital was outstanding.
Great. Thanks, Linda. Brittney, your comments on?
So I think this one brings about all the things we spoke about before to accumulate to when those happen, how quickly these matters can resolve and get everyone to a better stage than all of the previous cases that we have discussed get to. Someone in the comment box asked how we determine compensation, and that is jurisdictional. It depends, and it's also case specific. So, you know, if you have a wrongful death claim versus, you know, other med mal claims. So it really depends, but you have an economic side and you have a non-economic side to all of these cases, economics being lost time, lost wages, medical bills, that kind of thing. All falls under economics, sometimes, you know, expenses. Things that you can, you know, really monetarily add up. I think you should think of in terms of the economic side. The non-economic is your pain and suffering, and that's difficult to put a price on, especially when you know, it means something different to each individual, and so that is the part that is much more difficult to ascertain, but together that's how you kind of make up the compensation portion.
Great, and last but not least, Claire.
Thanks. The couple of questions I had were, was there an autopsy report done on this case? And as we're trying to determine the life expectancy of the patient, which is part of the damages, that may have some bearing if there was an autopsy report, but certainly, you know, what was the life expectancy of this patient had they not passed away? And how many dependents do they have? That's another consideration. So I think everybody else pretty much covered the important pieces of this. And it's remarkable that it settled as quickly as it did, because sometimes you'll encounter that emotionally, the patients and families just aren't ready to settle things that quickly. So I had a case once where I had an only child who was 40 years old, who she and her mother were on the spectrum, and she just wasn't ready to settle that case for a year. And sometimes we would meet, and I wasn't sure why we were meeting, but I felt like we owed that daughter the respect and whatever she needed to get through this process with her mother. And I get goosebumps even thinking about it. But I just think every situation is different, and every family group dynamic is different. So I think it's really remarkable that that case resolved as quickly as it did, and I think it's a tribute to the great organization and collaboration that was done by the folks involved too.
Great. Thank you, Claire.
Barbara, one topic we didn't discuss that I think is important through this whole thing is setting expectations. From each handoff, make sure you're setting reasonable expectations for the next person when they come in. So if you say, well, someone's going to contact you within 24 hours, then contact them within 24 hours. But also realize that, have I just set someone up for failure, right? Have I said, Linda's going to contact you in the next 24 hours? Little did I know, Linda's on vacation. So Linda's not going to be contacting them in 24 hours. So make sure if you put a deadline on something, I think that's always been, in every case I've been in, been very important to the patient and their family. You said trust. It's trust, and you lose it in a heartbeat by just doing one simple thing, which is missing a deadline.
And once it's broken, it is almost impossible to repair.
And if they trust you, most are very amenable to the time frame. If you explain, hey, I need you to know there's a lot of people, I've just gotten your information. There's a lot of people I need to touch base with. I can't do that overnight. I need to get medical records. That takes at least this amount of time. Setting reasonable expectations is everything.
So true.
So we are running to the top of the hour. A couple things. So first, thank you to all of the panelists for weighing in and working through this and sharing this with the audience. There's a question about, I don't know if we can address it quickly here. I just have a couple wrap-up slides, but the Medicare set-asides, there's a lot of complexity when figuring out future medical care, and certainly Brittney started talking about for future earnings, and then there's also this whole Medicare set aside. And I don't know, Brittney, if you want to attempt to address that in 1 minute or less, or
I'll do the best I can. Medicare is a barrier. I had a case that we quickly resolved with the family. We knew we wanted to resolve it with them. They were exceptional, but the bills had been billed to Medicare, and so you can't speed Medicare up regardless if you tried, and I have tried. And so it's a huge barrier. And so unfortunately, something that would have taken us 14 days to resolve took 9 months, and it literally was waiting on Medicare and not for a lack of time. So it's a barrier, it's there, we can't ignore it. And so there's not much we can do, but you have to stay diligent. But again, setting that expectation with the family, the moment we knew they were Medicare, I was like, hang on tight. We're going to do everything we can, but we can't do anything without Medicare. But it also goes back to hold the bills. Why not, right? When you see an adverse event occur, if you take anything back to your organizations, hold those bills until you know what the next step is. That's huge, and it can save you 9 months of time, because had we held those bills, it would have made all the difference.
Great, thanks, Brittney. I have 2 slides to wrap up and take us home. First of all, thank you all for participating and being committed to the Candor CRP process and improving it, not just at your locations, but within your states and through the partnership. And so there's 3 thoughts that we'd like to leave you with. So first of all, a resolution is definitely a team sport. And the terminology, as you heard, is evolving. And hats off to those of you that have identified early resolution teams or have specially trained your claims professionals along with your clinical leaders on the Candor process, so you all are in sync on the definitions, the process, and the importance of communication and partnership. And the second one is that tapping into your claims professional, your early resolutions team is really, really important. I guess our theme when we were preparing for this was early and often, and to notify and have them be part of the process so it flows and it works best for the patient and the families. And then the last one is the resolution comes in many forms, and it's not just financial. And I think there could be a whole conversation on the word resolution, and is it really resolved for families and for patients when they go through these terrible events, and for the caregivers. But basically our summary thought is that resolution comes in many forms and not just financial. And then the last part that I just like to go back, I always like to keep the patient and the family in the room. And thank you to Jack and Teresa for the great work that they've done to support all of our efforts and move the CRP Candor journey further down the track, is just remembering about our commitment to communication between one another and certainly with the family and patients, and that how important it is to have a signed contact person and to listen, as we remember, put our listening ears on as we go through this process. And transparency, I often refer to this as total transparency, and ensure that early communication and intervention clinically is really important for the physical healing and emotional healing for the patients. So with that, we'll remind us all that it's about the patient and family and not about the organization. But somehow I think when all of this comes together, it moves all forward, both the patient, the family, and the organization, to better outcomes for our patients. So with that, I thank you all.